We really have seen four very convergent sets of guidelines with some differences. Some of the differences are subtle and nuanced. Some of them are actually quite broad. And I think it's meetings like the NANETS and the ENETS and the CNETS meetings that are bringing some concordance and some consistency. Wouter, as you were talking about appendiceal carcinoid, I was reminded of a story which is, it stresses the importance of communication. My niece is now 50. When she was about 28, she had an appendiceal carcinoid found serendipitously at an appendectomy. And for 2 years she had her urinary 5-HIA measured. About 3 years ago, I was having dinner at a Chinese restaurant with her in London. And I said, oh, let's have the toffee banana. And she said, I'm not allowed to eat bananas. And I said, why not? And she said, because they will make my carcinoid come back. So for 25 years, she had faithfully followed the advice not to eat bananas when she was doing the urine tests, but had interpreted that as it was a risk factor in making a carcinoid come back. So I think one of the messages that has come out of this meeting for me, and I hope for you, is to ask questions and not to go 25 years misunderstanding something that you have been told. So whatever you have heard today, a lot of it is going to be uncertain when you go home and try and rethink and interpret it. So remember, if you get nothing else out of this meeting, ask your doctor questions. Doctor.
Can I make a comment? A lot of work is currently also going on with regard to how we do it. What I mean is that we are trying to produce some kind of state-of-the-art procedural guidelines. What kind of imaging do we need and how should it be performed? For me, it's very painful to see that about half of our patients are referred with inadequate imaging. So you need to repeat the CT, you need to repeat the MRI, you need to repeat the ultrasound, which is costing a fortune. And of course, if the referring hospital would have done the proper protocol, this would not be necessary. So I think we have really to work on that very hard. And this is not a Dutch problem. This is a worldwide problem. Another example I would like to give is, as you saw, I was involved in this insulinoma guideline. In the past, the blood test for insulin was a radioimmunoassay. And the way to look at insulin being produced by a tumor is like a car factory where you put in all the elements in the beginning, all the parts, and in the end you have a car. But these tumors sometimes produce incomplete cars. Cars with 3 wheels, cars without an engine. And that was also taking place in the insulinoma. So the insulinoma would produce different insulin molecules. So the old guidelines would say you need an insulin measurement. And with the radioimmunoassay, you could measure all the different insulins, all the cars with 3 wheels, without engine, with engine. But most labs have moved to robotic assays where robots do all the measurements and they use IRMA or IFMA or IEMA assays. The words are not relevant, but these assays only recognize the intact insulin molecules, so the car with the 4 wheels. So not anymore the car with the 3 wheels or the car without the engine. And that has resulted in a problem because some patients had hypoglycemias but not elevated insulin levels. And physicians would tell them, yeah, you have hypoglycemia, but not an insulinoma, which was in fact not true, because they were producing the other insulin molecules that were not picked up by the assay. So that's why you see now in guidelines that you need proinsulin measurements and C-peptide measurements. So in fact, this shows you that you should adjust or adapt the guidelines according to the state of the art and according to progress in research. That's why you can't stick with the 2007 guidelines. You need to revise them every 2, 3, 4 years. Thank you.
I'd like to just reiterate some of that, and that is that the baseline, when the day you're diagnosed and when you have your original scans, when you have a biopsy, when you have some blood tests, that has to be done very carefully and accurately and properly done. So as we know afterwards if you're improving and how you're improving, that's how we gauge whether it's going like this or whether it's going like that. And if we don't have that good baseline, and we have the 3 methods to get the baseline, we have the pathology. And there's one really good thing about the pathology. They drop your little biopsy or your hospital specimen, your surgical specimen, into formalin. They then put it into a little wax blocks, a little square thing like a dice. And that can be sent anywhere in the world. So if you go somewhere else, that can go as well. And they can take a slice from that original and say how it was then, even if it wasn't done properly. It's not so easy to go back in bloods because they tend in the lab to throw them out. And the radiology, if it's not good, it's not good. It has to be repeated. But you need this very good baseline to see how you're doing, how you're responding to the treatment. Or if you're progressing at all, like some tumours. I'll just give one example. I have a patient who's been with us for 29 years with a mid-gut carcinoid. He presented with 2 liver mets that we could see 29 years ago, so they were quite big. He went on to a somatostatin trial when that was at the beginning of the 90s with the somatostatin release of that drug. He liked it, he stayed on it, and he has 2 liver mets that are the same size 29 years later. So some patients don't progress.
And I think that actually is an important point. John brought up the NOT treatment, and Wouter, you brought up the risk-benefit ratio in terms of an intervention. How do you judge that, and how do you actually explain that to a patient who's obviously concerned?
Yeah, that's a difficult question. I was talking with some friends at the table. I will memorize a discussion I had in my own hospital. You know that we do a lot of peptide radioreceptor therapy, and patients are referred from all over the country and all over Europe. In Europe, especially in the EC countries, when there's a treatment available in another country, which is not available in your country, you can get a special form and you can send your patients to other countries. We used to send our patients for embolization to Paris. And then our radiologist said, why are you sending them to Paris? I can do that. And you know, the first results were really awful. And we were really not satisfied. And then we just decided to keep this guy out and to resend our patients to Paris. In fact, if we calculated the costs, the guys in Paris were much cheaper there than our own hospital. But apparently there are many colleagues that think that when they send a patient to another colleague, that they will never see the patient back, and that they will get a very negative publicity because the other colleague will tell the patient that he was mistreated or badly treated or poorly treated. That's absolutely not my experience, and that's absolutely not the case. And I think we should recognize that some centers are very good in some procedures. Same with surgeons. Like the big surgeon said yesterday, if your surgeon is afraid to operate on you, he's not a coward, but maybe he realizes that he's not skilled enough for this kind of procedure. And if he then decides to refer you to another surgeon that's an expert in the field, that's not a sign of weakness. I think that's a sign of excellence. And we should really appreciate that. So in fact, some of the Scandinavian surgeons are experts, and I know many patients from the north of the UK are sent to Sweden for surgery. Why not? I have no problems with that whatsoever. And it translates also into complications, survival, quality of life, everything. So I think we should collaborate much more than at this moment.
So again, it comes back to multidisciplinary teams and centers of excellence and expertise. Tom?
Just to echo that, and Dr. Buscom's comment about the group that aren't treated but are followed, 500 in his clinic, the two important points were made there, and that is that was careful monitoring, and the fact is there is a place, a unit that monitors and follows with the patient, and this kind of brings it all the way back to what you just said, Dr. McCune, that there has to be a coordinated group that can help guide those kind of decisions rather than a patient becoming too comfortable and walking away for a long time, which we've seen several times with the wrong impression. And then they come by and they're more advanced. So it's the monitoring and the follow-up and the clinical structure.
So can I follow again up on that? So we've talked about guidelines of treating patients who have diagnosed neuroendocrine tumors. Is there a way in which we can build guidances for the identification of patients? I think, Joy, you said that patients would maybe be seen once in a GP's lifetime. So how do we actually help our clinical colleagues who are not experts identify patients before they come to us with extensive metastases?
I think it's not even once in a general practitioner's or a family doctor's lifetime. Sometimes it's once in a gastroenterologist or an endocrinologist's lifetime almost, depending on where you are. So if you've only got one patient, you can't be the best person to, one patient with a particular disease, you can't be the best person to look after that. It has to be somebody with experience. But Tom O'Dorizio said yesterday, and we do this in Belfast, Ireland's quite a small population, and we have one medical school in the north of Ireland, which is part of the UK. And we teach the medical students about neuroendocrine tumours. So in first year they get a single lecture and the opportunity to do a student-selected module. In other words, they'll do quite a lot of work on that, and they'll study one patient for 10 weeks through their chart and things like that, through their references. And then again in their fourth year, the year before their final year, they'll have a series of about 5 lectures. Now, we feel that we have got a bit of a captive audience there, and for many years the Northern Ireland population didn't tend to move about. And when we were looking at the incidence of neuroendocrine tumours in Northern Ireland, we thought they were quite high, actually. And it wasn't that. I think the information was out there. We have to get into the medical schools where doctors are being trained. We have to get into the postgraduate training amongst the groups of doctors that might be seeing these as first referrals. And we have to raise the level of awareness. You have to think zebras as a doctor, even though it's not your field. There has to be something that triggers the thought, I see hundreds of patients with irritable bowel, but this one might be different. This one, think zebras.
Yes, still it's difficult. I mean, we organize meetings, we always see the same faces. So there are also the faces we don't see. We can publish new information, but if you don't like sports, you don't read the sports page. So that's the same for physicians. If they're not interested, they won't read it. So in fact, you need to approach the students and the physicians, but also in the medical meetings. And I think it's a disgrace that a big endo meeting pays so little attention to this endocrine disease, and the same goes for oncology meetings and GI meetings. So that's where we should really do the work, and really should show our colleagues what we are doing. And I think it's improving, though.
It's slowly, yeah.
I'm fortunate enough to have worn several hats in my career, and the first hat I wore was as a primary practice rural family doctor. And it's speaking from that hat, it's almost impossible, because you get bombarded as a family doc with millions of things, and you get another educational experience was like right where all the rest of them go, in this ever-growing pile, and you've got to keep your heads above water on the common problems, let alone the relatively rare ones. We've acknowledged this by teaching the medical students and targeting the internists and the surgeons. And then we've just hired a new head of surgical oncology who's very keen at targeting the practicing surgeons, the gastroenterologists, et cetera, to identify this, especially the rural ones, because 40% of my province is rural. And to identify these patients, to say this is the symptom complex, and to bring them forward to us as soon as possible. But it is very difficult, and the primary care physicians are bombarded with a whole pile of things. And the last thing you think of somebody with irritable bowel, which I saw hundreds of them, is that they have a carcinoid tumor.
Yes.
Maureen.
Okay, a couple of questions, couple of comments and questions. I appreciated what Dr. De Herder said, especially in regard to encouraging the idea that a surgeon who would refer a patient rather than do the operation himself or herself is greater than, it's better to do that than to try to do the surgery yourself. And I'm not quite sure about the level of mobility in Europe or in the UK in regard to seeing different specialists for, I know that we're talking about networks of expertise, but and in one centre, but also I guess you could have networks of expertise in many centres that would become a very large network, so that you could go from, say, one country to the other in Europe, or one county to the other in the UK and Ireland. Is that quite, that's my first question. So is there a fair degree of flexibility in Europe and in the UK and Ireland in terms of where you go?
In the UK, there is a lot of flexibility about moving around the country. And when we set up the centres of excellence, for want of a better word, for example, in our centre in the early, in 2002, 2003, 2004, we did Yttrium 90 treatment. But we weren't having so many patients coming through that were requiring that with the population that we're serving. So after a few years, we thought, well, lutetium was coming on the cards as well, and that was another option for patients. And we thought that it was crazy that we would try and keep at the forefront of this with such a small population. So we send those patients to London. And in fact, as we speak, we have a patient who's doing her second session with Yttrium 90 in London in the Marston Hospital. So there's quite a lot of movement. There's only 2 laboratories serve the whole of the UK, one in Hammersmith in London, one in Belfast. And there's other things. Occasionally, and not regularly, but occasionally patients will have a liver transplant, more often with a pancreatic tumour than with a gut tumour, and they will only go to certain centres in the UK. So within that one country and the National Health Service, there doesn't really have to be a transfer of money. It's a paper transfer. We also, from our centre, send a number of patients who want a second opinion right outside the country. Mm-hmm. So we'll send them to Sweden. Okay. And that is quite easy, and that is funded. Quite easy is a bit unfair. It's not just as easy as sending a patient to London, but it is funded and it is available. And we would have had a dozen patients that I can think of their names that have gone to Sweden.
And do they pay their own transportation, or does the UK pay for it?
They'll get it back. They'll get it back, provided they wait for the paperwork to come through. And it does take a few weeks, but it doesn't take years.
Okay, that doesn't happen in Canada. And one last question. Somebody gave me lung carcinoid patients in Canada. Just looking here. Is there a sort of a consensus on lung carcinoid patients with bone metastasis in the Canadian consensus statement?
No, the Canadian consensus statements for well-differentiated GEP tumors.
So it's still to come?
Not certain. You'd have to talk to Walter about that. I suspect now that we've got this hurdle out of the way, we'll start tackling the rare tumors.
Okay.
I'm not certain, but that was at our last meeting, which was a while ago. This was raised as a future project.
Okay, thank you.
Okay,
I think it's pretty close to the break.
I'm mindful
over the break.
I'm mindful of the time, and I suggest that we go for a break. 10 minutes just to stretch legs, and we'll move to the next session. Tom, is that okay?
Just a comment, yes. I think that's a big issue, too, in the NANETs, namely that the the pulmonary carcinoids have not been included. And I really think that I know Europe, for one, has expertise, very good expertise, and I think that needs to be folded in all the consensus guidelines as soon as possible, because that's a whole group that 25% of folks that should have guidelines in that as well.
So thank you very much to manage.